Good morning, everybody. Assalamu alaikum. I'm Dr. Zahra. I am one of the newest addition to the ER department. I'd like to say I'm glad to finally meet all of you. Today, my presentation is about acute unilateral lower limb swelling. So the general approach for patients with acute unilateral or asymmetrical leg edema is as follows. What is the first thing that comes to your mind when you hear acute unilateral lower limb edema? DVT, arthritis, cellulitis. Thank you. Okay, so the word that I was looking for is the DVT, because the general approach as recommended is to determine the clinical probability of DVT and perform the appropriate diagnostic testing depending upon the clinical probability. For the best studied production tools, we have the Wells score and the modified Wells score, as it will come later in the slides. After that, if the DVT is ruled out, we can look at other differential diagnoses. So today's learning objective, differentiate the common causes of acute lower limb swelling, recognize the red flag features requiring urgent intervention, key history and examination finding in each presentation, apply evidence-based algorithm to evaluate acute leg swelling, point of care ultrasound pulse and acute swelling assessment. Starting with the DVT, as we have to rule it out first, what is the definition of a DVT? It's a formation of one or more blood clots in deep vein, typically of the lower extremities. As you know, we have two networks of the venous system. We have the superficial venous system and we have the deep venous system. The deep venous system is the one that drains the muscles and the internal structures of the leg, whereas the superficial veins drains mainly the skin and the subcutaneous tissue. For definitions, we have proximal DVT, which means that it affects the femoral, profunda femoris or popliteal vein, up to the calf vein trifurcation. So coming from the femoral vein, popliteal vein, and the external iliac vein, this will be considered a proximal. When we talk about distal DVT, it means the veins which are beyond the calf vein trifurcation, which is below the knee joint. When we say venous thromboembolism, we mean that there is DVT and a PE at the same time. When we say provoked DVT, it means DVT with a risk factor. Unprovoked is a DVT without a risk factor. When we talk about the risk factors or the etiology, we always focus on the Virchow's triad, which is three things. We have the venous stasis, and we have the hypercoagulability status, and we have the vessel wall injury. As remembered by this mnemonic, which is thrombosis, T for trauma or travel, especially long travel, which will lead to venous stasis, especially if the person is not moving. Hospitalization/hormones. The hormones, especially the oral contraceptive pills or the hormonal replacement therapy containing estrogen, are for relatives, any family history of DVT or any thrombophilia in the family. O for the old age, M for malignancy, especially gastric cancers, pulmonary cancers, urological cancers. These cancers, they produce cytokines and proteins that promote thrombophilia. Bone fractures, obesity/obstetrics, especially when the person is pregnant, because pregnancy as itself is a hypercoagulable status. Smoking/surgery, especially if the patient has been put to bed rest for more than 3 days, immobilization, and sickness. Moving to the history and the clinical features, usually the patient will present to us complaining of acute unilateral asymmetrical leg edema, might complain of calf tenderness, pain, or firmness along the course of a vein, erythema, or warmth. So the clinical trial sensitivity and specificity reported that the symptoms that are reported by the patients are as follows. For the swelling or the edema, 97% and 33%, pain 86 and 19%, and the warmth 72 and 48%, making the swelling and the edema the most sensitive symptom for the DVT, which brings us back to the first statement that I opened with, is whenever a patient comes with lower limb edema, especially if it is acute, you have to rule out the DVT first. If it is a proximal, the pain will be in the calf only. If it is distal, if it is a proximal, the pain will be in the calf or the whole leg. Whereas if distal, it could be in the calf. Also, the patient may present with the complication of a DVT, which is the PE, like shortness of breath, palpitations, chest pain, hemoptysis, dizziness, and syncope. On examination, you will notice that the patient might have unilateral edema, swelling, difference in the calf or thigh circumferences between the two limbs. Upon palpation, there will be warmth, tenderness, and erythema compared to the other limb, and tender cords because of the inflammation or the bulging of the superficial veins. There could be also local or generalized signs of malignancy, like an inguinal mass, because malignancy could be the provoking for the DVT. The distal pulses could be normal. For the Holman signs, although it's always mentioned in textbook, when you dorsiflex the foot, it will elicit pain in the calf, but it is unreliable for the DVT because in many patients it could be false positive. Mayer sign, it is compression of the calf muscle, which causes the pain, and Payer sign is pain when the pressure is applied over the medial part of the sole of the foot. Moving to Wells criteria, when we are going to evaluate for the pre-test probability, we are always going to use Wells criteria to evaluate. Wells criteria contains 7 things. For each, you will give 1 point, except for the last point, you will subtract 2. So if the patient has an active cancer, they will get 1 point. Immobility more than 3 days or a major surgery less than 4 weeks, they will get 1 point. Calf swelling, which is more than 3 centimeters compared to the other calf, they will get also 1 point. And how do we measure the calf swelling? We have to measure it from a certain point. Usually we use the tibial tuberosity. By a measuring tape, we go down a certain distance or a fixed distance in both sides, and then we measure the circumference. If the difference is more than 3, they will get 1 point. Collateral or non-varicose superficial veins present is 1 because, as you know, the superficial veins, they will drain into the deep veins. If the deep vein is blocked, then the perforators will have the backflow into the superficial veins. The entire leg is swollen, they will get 1 point. Localized tenderness along the deep venous system, 1 point. Pitting edema greater in the symptomatic leg, 1 point. Paralysis, paresis, recent plaster or immobilization of lower extremity, 1 point. If they have a previously documented DVT, they will get 1 point. If there is an alternative diagnosis for DVT or others are more likely, you will subtract 2 points. So you will add all of them together. If the score is between -2 and 0, this is a low risk for DVT. 1 to 2, moderate risk for DVT, and above 3 is a high risk for DVT. For the modified, they just classified it based on 1 to 2. Below 2 is less likely to have DVT, and more than 2 is more likely to have DVT. This is just to make it easier for the clinical aspect. Moving to the algorithm. So the first thing, we will assess the pretest probability by Wells score or other method like modified Wilson score. If it is a high pretest probability, we will go ahead and perform compression ultrasound. Compression ultrasound means that we will use the ultrasound to try and compress the veins, because as you know, veins are usually compressible because they have thinner walls. If the vein is non-compressible, then this could be a sign for DVT. Sometimes they do the whole leg. It depends on the institution. If it is a not high pretest probability, low or moderate, we go for the D-dimer. The D-dimer is not diagnostic for the DVT. We just use it as to guide us to order the more confirmatory tests to the DVT. So according to the value or the result, if it is above 500 nanogram per milliliter, you will go ahead and perform the ultrasound. If it is less than 500, then the DVT is excluded and you can observe clinically. When you perform the compression ultrasound, if there is a high probability and a negative compression ultrasound, what are the options? If the whole leg compression ultrasound is not performed, it has to be done. Or the other option is to repeat the ultrasound at day 3 and day 7 of the symptoms, or perform the alternative imaging studies. The alternative imaging studies are either the CT venogram or the MRI venogram. If it is a positive study, then of course the DVT is diagnosed. If one of the tests that was performed here is positive, DVT is diagnosed. If it came negative, although the patient has high probability, additional testing is not required, and the patient should return immediately if they have any persistent symptoms of the DVT. And if there is a moderate pretest probability and a negative compression ultrasound, you will do the whole leg if not performed, or they will do the serial 3 to 7. If it is positive, DVT is diagnosed. If it is a negative, then DVT is excluded. It's worth mentioning that universally, they usually depend on the compression ultrasound, but it's better to use the Doppler as well, because the Doppler will help us in better evaluation of the deep non-compressible veins like the iliac vein. And if there is no flow, then the vein is blocked. So this is how the Doppler looks like, or the ultrasound. We perform it at multiple levels. We check for multiple veins. So this is point number 1. This is the common femoral artery, common femoral vein, and the great saphenous vein, which is one of the superficial veins. If it is normal, you should see both of the veins compressed. But in DVT, you can see that it will not be compressed, and there is also like a mass inside. The second point, this is the femoral artery, femoral vein. Again, the vein should be compressed. If it is not compressed, this should alarm you that this is DVT. Among the course of the popliteal, the same thing. If it is compressed, this is normal. If it is not compressed, this is DVT. For the management, before deciding the treatment, we should always assess for the bleeding risk and the contraindications for the anticoagulation. The absolute contraindications for the anticoagulation: active major bleeding, acute intracranial or spinal hemorrhage, major trauma, either intra-abdominal or intrathoracic, recent planned or emergency high bleeding risk surgery procedure like AAA repair or exploratory laparotomy or craniotomy. If there is a contraindication, what we will do is we will place an IVC filter, which is an inferior vena cava filter. This is basically inserted by interventional radiologists to catch the clot from going into the lung and causing the pulmonary embolism. If it is a distal DVT and there is contraindication, you will do serial ultrasound. For the anticoagulations, the recent recommendations recommend the direct oral anticoagulants as the first line. The second is the warfarin, plus minus the bridging by low molecular weight heparin or unfractionated heparin. For the agents like apixaban, they don't need the bridging, so they can be immediately started orally. But for dabigatran, for example, it will need a bridging. If there is a threatening to the limb, if it is a massive DVT, then there is also the catheter-directed thrombolysis, which where a catheter is inserted inside the thrombus itself, and we inject the TPA or a thrombolytic agent to dissolve the thrombus or thrombectomy. Moving to the second differential, which is cellulitis or erysipelas. Cellulitis or erysipelas, both of them are non-purulent soft skin or tissue infections. The cellulitis is a local infection of the deep dermis and subcutaneous tissue. We can differentiate between it and the erysipelas that it has a poorly defined border. As you can see, there is no demarcation and there is induration. For the erysipelas, it is a superficial infection which involves the upper dermis, where you will see that it is sharply defined. There is like a border and it will be raised. The clinical features are similar in both of them: the erythema, the warmth, the tenderness, and the edema, plus minus the lymphatic edema, which could present like peau d'orange, plus minus reactive inguinal lymph node, because this is an infection at the end of the day. It could present as bulla. Purulent cellulitis could happen as well. In severe cases or in patients who are immunocompromised, they could present with fever, chills, confusion, nausea, headache, muscle, and joint pain. The etiology for the cellulitis or erysipelas is similar, which is entry of the bacteria through minor skin injury like cracks, ulcers, blisters. Even in some patients, tinea pedis could serve as an entry point, or even insect bites. The etiology, the most common cause is beta hemolytic streptococcus group A, which is S. pyogens. The diagnosis is mainly clinical, plus minus the labs or the imaging for the severity assessment, or if you are suspecting other things. So here you have the ultrasound. As you can see, this is the subcutaneous tissue, which resembles what we call cobblestoning. And this is what is usually seen on the ultrasound if the patient has cellulitis. For the treatment, it is antibiotic, which should cover the group A streptococcus, including cloxacillin, cephalexin, and clindamycin, although clindamycin is not preferred. If moderate to severe, ceftriaxone, vanco, piperacillin, tazobactam, or meropenem. For the systemic symptoms, or if the patient has comorbidities, or if you gave an outpatient treatment and it failed, they will need hospitalization for the IV antibiotics. Other than that, limb elevation, rest, and pain management is also part of it. The next thing is the calf muscle tear or pull, defined as sudden ballistic movement involving lower extremities, such as sprinting or jumping. History, usually the patient inciting injury in an athlete or an old patient with comorbidities like CKD patients. In the physical examination, they will have severe tenderness to the calf muscle, active plantar flexion and passive dorsiflexion. Both of them, they elicit the pain. A negative Thomson squeeze test, which we use to test for the Achilles tendon rupture, which should be negative. For the imaging, on the ultrasound, we can see hematoma or fluid collection. So this is the gastrocnemius muscle, which is one of the calf muscles. This is the soleus, and you can see there is a tear with hematoma collection in between of them. The MRI, of course, is the gold standard. The management depends on the case, either conservative or in more severe cases could be evacuation. The next thing is a ruptured popliteal or Baker cyst, which is a synovial fluid-filled distension of a bursa in the popliteal fossa. Usually it's caused by inflammation, and the inflammation will cause the excessive production of the synovial fluid, and this synovial fluid will start to form a cyst. So this cyst, when it ruptures, the fluid of the cyst could leak, and it will go down into the calf muscle. And this, we call it pseudothrombosis because it mimics the DVT. For the history, the patient could have risk factors for inflammatory, degenerative, or traumatic intra-articular changes in the knee joint. For example, rheumatoid arthritis, osteoarthritis, or meniscal regions. They could complain of posterior knee pain, knee stiffness, locking or clicking, calf swelling, and pain if it is ruptured. For the physical examination, positive or minus mass behind the knee if it is not ruptured, the calf swelling and the pain if ruptured, and the crescent sign, which is caused by the fluid leaking down. It will cause discoloration at the ankle region, which resembles a crescent. The diagnosis is mainly clinical. The ultrasound usually done to rule out DVT, and it will show the cyst and the fluid going down around the calf muscle. So you can see this is the cyst. And this is the fluid which is going down. This is the muscle, this is the subcutaneous tissue, and this is all fluid coming down the calf. For the management, mainly it's ice pack and knee support. In advanced cases, maybe they will need surgery. This is the crescent sign that I was talking about. You can see there is slight discoloration of the leg that was affected, and there is also swelling of this leg. May-Thurner syndrome, usually the patient will present as a young female in 20s or 30s who presents with acute or chronic pain and swelling of the entire left lower extremity with or without the venous thrombosis. The etiology is the compression of the left iliac vein, this one, between the overlying right common iliac artery and the fifth lumbar vertebra. So this will cause venous stasis, and because of the venous stasis, it will result in the swelling, and it predisposes them to having DVT because of the venous stasis. Other differentials, a leg swelling in a paralyzed limb, especially because it's not being moved. It could be also lymphangitis or lymph obstruction, in which case it will present as red streaks going with the direction of the lymph node. Superficial thrombophlebitis, venous insufficiency, as you know, it could present bilaterally, but if one limb is more affected, could be more apparent on that limb, and in cases it could be idiopathic. For the resources, mainly I used UpToDate, AMBUS, and BMJ case report, and thank you.